All right, gang, you're amazing. Let's shift gears from sort of adjuvant therapy and rectal cancer to metastatic disease. A lot of stuff going on here. Clearly, colon cancer is more than one disease right now, anatomically, molecularly. Bert, how and when do I do molecular testing? I would never, ever, ever take care of a breast cancer patient without knowing HER2, ER, PR, and the like. And yet I see lots and lots of patients with colon cancer, zero molecular testing when we start out. What's the right answer to when and what do you send?
Well, I think off the bat, you should ideally have their RAS status, KRAS and NRAS. You should probably know their RAF status up front, BRAF. We should definitely know their MSI status. The tougher question is, should you order a bigger panel than that early on versus waiting until later? It's interesting for us. Our own pathology department was running sort of a small colon panel for a while. They've shifted gears recently and told us, go ahead and just send these to Foundation. So now I don't even have a choice. I'm getting more than that information I just mentioned right off the bat.
Well, some of the next-gen panels give you MSI maybe better than that, and you get some TML and some other things. So I think there's clearly a shift towards broad panels. But let me ask the hard question, Marwan. Do you start therapy? That patient wants treatment, right? And often the only biopsy you've got is a little alligator snip from the colon primary, with maybe not a biopsy of the metastases, right? And that's going to take, what, 10 to 14 days for that result to come back. Do you wait or do you start?
I start. I mean, let's face it, there's zero evidence that lack of 2 cycles of targeted therapies does anything bad to a patient, right? So patients are anxious, you want to start, you want to attack the cancer, they have extensive disease. I think starting with FOLFOX or FOLFIRI, if you prefer, or for some FOLFOXIRI in certain instances, may not be an unreasonable approach while waiting for the next-gen sequencing data, and that's what we do in our practice.
I've got right now a patient who's 34 years old with a tight sigmoid lesion and a liver full of tumor, symptomatic. Her profile's cooking. I happen to know she's microsatellite stable. What should I give her while I'm waiting on my RAS to come back?
First of all, how tight is that sigmoid?
She's needing significant laxatives to move.
Because I think that, you know, really the emergent situation is, do we need to put a stent in that sigmoid to keep it open?
I don't want to put a stent.
So I think that starting chemotherapy right away.
But which drug? So what should I use?
So this is a left-sided tumor.
I don't know my RAS or BRAF yet.
We don't know the RAS. So again, I think
I will in 4 days.
You will in 4 days. So I think that starting with chemotherapy, such as either FOLFOX or FOLFIRI, depending on is she, you know, concerned about neuropathy or not, or other GI toxicity, I think either one of the regimens is an acceptable way, and considering potentially adding an EGFR targeted agent if your RAS comes back wild type.